And I'm going to get started with the presentation. And I'm going to introduce both Adam Hamilton and Dave Hambrick, and I'm going to let them take it away.
All right. Good morning, everybody. Thank you for joining us today. I'm going to just give a quick overview of what we're going to cover, and then I'm going to hand it over to Dave, and he's going to get into some of the specifics with you here. Essentially, we're going to provide a brief overview of DLA 20, how we use it in our system, and then we are going to talk specifically about how DLA 20 is used with specialized residential. There'll be, as Tricia mentioned, an opportunity for everybody to ask questions. One of the things we're going to encourage today is if you have specific questions about an individual circumstance, that we save that maybe for reaching out to customer services here, and we can troubleshoot those things on a case-by-case basis, and we can really stick to covering the larger topics today. That way we don't have anybody's privacy in peril, and we can answer all the questions and get to all the topics that we want to regarding DLA 20. Okay, so with that, I'm gonna let Dave step in here.
All right, good morning. Quick overview of the DLA 20. The DLA 20 was utilized to determine the appropriate acuity tier for individuals transitioning to new providers and for individuals new to specialized residential services. In FY20, the DLA 20 is utilized to determine the appropriate acuity tier for all individuals receiving specialized services in our network. The DLA 20 is a research-backed assessment tool. It measures the individual's functional strengths and needs across 20 separate daily living activities. This measures the intensity of the supports needed so the individual can receive services suited to their condition. Because all human beings have a hierarchy of needs like health, housing, food, supports, movement within our communities, personal care, etc., the DLA 20 can be used across different types of disabilities within different cultural groups and for individuals living in different settings. Now, who administers the DLA 20 assessment? Trained supports coordinators and case managers are trained to complete the DLA 20 assessment with adults who present with mental illness, comorbid substance use, and or comorbid intellectual and developmental disabilities. To ensure integrated reliability, only trained coordinators and case managers can determine the score for each of the functional dimensional anchors. Supports coordinators and case managers and individuals receiving services, their natural and paid supports, collaborate to understand the strengths and needs across all of the 20 functional dimensions of the DLA 20 assessment. How often is the DLA 20 administered? With adults presenting with mental illness at intake, at targeted case management level every 6 months, and at the and specialized residential service levels quarterly. And always remember that the DLA 20 can be administered more frequently as significant changes in the individual's functioning are apparent, suggesting an individual may have needs requiring a new assessment. For example, hospice. With adults presenting with intellectual and developmental disabilities, the DLA 20 is administered at intake, at the time of the periodic review, and minimally every 6 months. And the DLA 20 may be administered more frequently if needed, as mentioned before. Why do we use the DLA 20? The DLA 20 identifies functional dimensions with which individuals' supports are needed and the functional dimensions that are strengths. This helps inform plans of service, what types of supports each individual needs, and how the supports intend to assist the individual. Okay. The DLA 20 helps establish medical necessity, which has three components: symptoms resulting in a diagnosis of mental illness and/or intellectual or developmental disability. The diagnosis must be current within the past year or updated. And it measures a functional impairment that substantially interferes with one or more of the daily living activities measured by the DLA 20. Also, the DLA 20 demonstrates changes in functioning as it is re-administered across time. If an individual is experiencing increased functional impairment, the DLA 20 assessment tool will indicate that more intensive supports and services are necessary. Conversely, if an individual is experiencing decreased functional impairment, the DLA 20 assessment tool will indicate that less supports and services are necessary.
Okay. I'll add to what Dave said by saying that in healthcare, increasingly, we need tools that help us measure these things and measure the outcomes for the individuals who are receiving services. In healthcare, we're seeing lots of movement toward more performance-based payment models, and it's going to become increasingly important for providers to be able to show that the services that they're providing are effective. With an increased system design around the integration of physical and behavioral health care, we're also going to need tools that help us look at how much support an individual needs in taking care of their physical health care needs. So this is also one of the things that DLA 20 is very useful for. I'm going to talk to you a little bit about how we're using the DLA 20 in general, and then I'm going to give some special attention to specifically how we're using DLA 20 within the specialized residential level of care. As you probably know, and as you're probably particularly interested in at this point, we're using DLA 20 within specialized residential to determine the level of acuity that an individual presents with. And this, of course, is helpful in planning for supports and as a direct correlate to the rate that the residential provider is paid. In addition to that, DLA 20 is extremely useful with developing plans of service. As Dave mentioned, we're identifying an individual's strengths when we administer the DLA 20. We're also identifying areas where an individual is going to need supports. These things can be integrated into a treatment plan, and then we can monitor on an ongoing basis by re-administering the DLA 20 how effective those supports are at helping an individual meet their needs. As Dave also mentioned, DLA 20 is extremely important for establishing medical necessity. This is a requirement for all Medicaid covered services that supports and services are found to be medically necessary. I'll say a little bit more about the DLA 20's use within specialized residential. Again, the outcomes of DLA 20 indicate how much support is needed. So if someone needs more support, that should be captured in the DLA 20, and then services can be put in place and designed around the areas where more supports are needed. If somebody's improving over time, if somebody requires less supports, of course, we would want to make those adjustments as well. Regarding the implications for rates, we needed a fair and equitable way to determine how specialized residentials were going to be paid for the services that they're providing. We wanted to be able to do something that was consistent across all providers, and we wanted to be able to do something that was really based on an understanding of the specific needs that the individuals who specialized residential providers are supporting have. So again, we looked to DLA 20 to help us with this. And what we're really trying to focus on when we're thinking about rates, what we find to be the primary driver of the rate is how much direct staffing support an individual is going to require. So DLA 20, because it looks at the amount of supports needed overall and then gives us some specific areas to focus on where supports might be needed, really helps us have a clearer picture of the amount of staffing supports we feel an individual is going to require. And as I alluded to previously, DLA 20 is a good tool for looking at outcomes. Improvements in functioning in certain areas should be captured as DLA 20 is administered across times, and supports and services can be adjusted accordingly. And of course, if somebody is needing more support, if somebody has new challenges that have come up and they're going to need additional staffing and supports, we would want to have a way to identify the areas where those supports are needed. And we want to be able to see over time, are the supports that are in place getting somebody the outcomes that we think that they are going to get. There's been a lot of questions about how the DLA 20 is scored. Again, I understand that this is largely due to the fact that the outcome is crosswalked to a rate, so people want to understand how the scoring impacts the rate that's ultimately going to be paid for the services that are provided. There are supports coordinators and case managers across our system who've been trained and at times retrained in the use of DLA 20. It's really the responsibility of the supports coordinator or case manager to ultimately decide on the score for each item on the DLA 20. This is the way that we ensure that the tool is being scored appropriately. Where lots of collaboration can begin to happen is other paid supports and natural supports can have the opportunity to provide information about their observation of the individual's needs, their observations about where an individual has strengths, and the supports coordinator and case manager can weave all of that information together to develop scores for each anchor on the DLA 20. Again, we're looking at places where people have needs, places where people have strengths, and we're trying to make sure that all of the core providers, supports coordinators, and case managers understand that we need all 20 of those items scored. That helps us get to the clearest picture of an individual. This works best when information from as many sources as possible are pulled together, and the sports coordinator and case manager can make a well-informed decision about an individual's functioning in each area on the DLA 20. There's also been some concerns and some questions about the accuracy of DLA 20 scores. As I mentioned, it's important to score all 20 anchors. We certainly understand that initially, if someone is new to services, perhaps going through intake, it may be difficult to score some anchors because we are gathering that information, but really that would be the only time that it might make sense to not score an anchor. All 20 daily living activities are relevant to everyone's life, and once we have time to gather sufficient information, all 20 anchors can be scored. Again, the reason for this is we want to assess strengths and needs across all 20 items on the DLA 20. We want to be able to make sure that we're finding all of the areas where an individual may need support and identifying all the strengths that a person has, because this becomes really crucial when we are designing plans of services and developing plans to provide the supports to people in different areas of their life. So that brings us to the end of the structured presentation. And now what we're going to do is shift gears and try to address specifically some of the questions that were brought to us related to DLA 20 and its use within specialized residential.
Okay. How does a person's relationship with family impact their support needs, i.e. cost of support in a licensed residential setting? This topic is one of the 20 assessed anchors in the DLA 20. It is very positive, very maladaptive family relationships can affect multiple assessed functional dimensions in these anchors, i.e. treatment costs. In a quick discussion, positive relationships can help overcome treatment resistance, provide stability, provide reliable treatment history, encouragement, and aid the individual in advocating for a life of their choosing. Maladaptive relationships have dissuaded individuals into not participating in treatment, reinforce and individuals with developmental stigma, demoralize and disempower the individuals we serve into not wanting to have goals for their lives. In extreme cases, the supports and interventions focus on recovery from past trauma inflicted by a family member.
I'll just add to that regarding the cost to support an individual, it's certainly the case that if an individual and their circle of natural supports choose to have the natural supports provide supports in some of the areas where needs are identified, that could bring down cost of service. I guess the example that comes to mind would be if somebody has natural supports who prefer to take them to medical appointments or something along those lines, then the cost to provide that support would not be on the specialized residential provider, rather the natural support would be doing that. But the other thing to bear in mind is that we're talking about our highest level of care within our system. So generally speaking, people are going to have multiple service needs in multiple areas of their life where they are going to need support. So really, when we're looking at how the DLA 20 is used, we're acknowledging that individuals are already eligible for this level of care based on the amount of support that they need. So it's certainly encouraged, and we want people to utilize their natural supports where possible, and we recognize that multiple support needs are likely identified. Okay, let's look at the next question here. The next question, why do some acuity levels seem far off from actual client need?
Okay. There's a few reasons. The number one reason is missing DLA 20 scoring answers. Basically, if there's no score in the anchor, there's no staffing weight. If there's no staffing weight, there is no pay for the home provider to staff appropriately. The second and third reasons are what we call the rose-colored glasses effect on comparing individuals served through the caseload instead of the national norms inside of the DLA. Examples, we're addressing reports of case managers and sports coordinators not wanting to give a low score on a dimension, like the bad thing, or a judgment, or being afraid that they're going to offend the family. We're also having reports of case managers and sports coordinators saying, well, compared to the rest of my caseload, this individual is doing great, but that's not following the DLA 20 scoring rules and norms and dimensions that they have to follow. And finally, if an individual has been adjudicated not guilty by reason of insanity or incompetent to stand trial or some other legal reasons, they might be presenting with lifelong needs across multiple assessment dimensions to protect the individual and to protect the community. So their needs might be different, even though the presentation might say otherwise.
Okay. The next question is, what if the DLA 20 question is not applicable to an individual?
We truly wish this was the case. We can all agree that individuals are not their diagnosis or their presenting functional disability. that even with the same diagnosis and the same disability, individuals can present with very, very different needs. What we have found by reviewing the incident reports, hospital reports, police reports, sentinel events, death reviews, and listening to the MI and IDD individuals that we serve is that both MI and IDD individuals commit crimes just like the rest of us, are frequently victims of abuse, whether it be sexual, physical, or emotional, frequently victims of neglect and exploitation due to being vulnerable, that they use, abuse, sell illegal drugs, prescriptions, coffee, cigarettes, etc., that they're interested in sex, having meaningful relationships, getting married, having children, etc., that they want meaningful work and extra income to a job, volunteering, etc., that they want to be a part of the community, that they want to be a part of religious events. They don't want the religious person to come to their house. They want to be a part of that community, that they want to live self-directed lives, even if they always need staffing and support, and they want others to treat them with dignity and respect.
Again, like we mentioned during the presentation, really the only reason to not score an item on the DLA 20 would be if you can't get the information to develop an accurate score. Otherwise, we can expect that sports coordinators and case managers are working to gather the necessary information to make sure we're identifying all of the areas where a person might need supports. Okay, next question. Do case managers complete DLA 20 without staff's input?
Okay. Even if the individual serves guardian, family, home staff, doctors, etc., gives input, it is the case manager's and sports coordinator's job to use clinical judgment and the DLA 20 scoring rules and norms to complete the assessment. Here's two examples of a discrepancy. Of an individual reporting discrepancy, the first one. An individual reported, "This is not illegal drugs. I'm using non-Western medicine provided by my herbalist." Or a doctor's treatment order discrepancy. An individual reported, "I do not have back pain. I just tell the doctor that, so he gives me oxycodone. Then I sell it so I can pay rent for my family."
As we mentioned during the presentation, sports coordinators and case managers are collaborating with other paid supports and with natural supports to gather as much information as possible to develop accurate scores on the DLA 20. This is a crucial part of the process and helps to make sure that we're identifying all the areas where a person has strengths and a person has needs that are going to require supports. Where there might have been some confusion is around the scoring of the tool itself. Again, it's really incumbent upon the trained person, the sports coordinator or case manager who's been trained in the administration of DLA 20 to develop the actual score. That's really not a collaborative process, because if the tool is going to maintain inter-rater reliability, we need to make sure it's scored by a person who understands how to score it according to the rules that were developed. Okay, next question. Are case managers encouraged to complete the assessments with clients and home staff?
Case managers and sports coordinators are required to continually integrate this information from all treatment providers, natural supports, and community supports. Then coordinate care as a part of the person-centered planning process. Since not all information is from one source, the complete assessment could be delayed.
Okay, next question. Is there an appeal process if a provider does not agree? So I think this is specifically about specialized residential, and if a specialized residential provider does not agree with the outcome of the DLA 20 and the level of acuity that an individual is identified to have, is there a way that the provider can appeal that? We've certainly worked through some unique situations on a case-by-case basis, and I expect that we'll, at some level, need to continue to do that. However, we are developing a process by which specialized residential providers can request a review of their rate, and that will, of course, include staff here going back and looking at the tools that were used to determine the rate, specifically DLA 20. That process is being developed. As many providers already know, we had a less formal process as we transitioned from FY19 to FY20, and we're moving on to the new rate methodology, and providers were able at that time to submit requests to have their rates reviewed so that we could adjust where necessary, and that process involved folks from our clinical team here looking at several DLA 20 assessments, and at times asking that core providers send sports coordinators and case managers back out to work with people and their paid and natural supports to have a new DLA 20 completed, and rates were adjusted accordingly. So that's been an ongoing process, and we're looking to formalize something moving forward.
To interject 1 second, I want to let providers know that we have previously done webinars on our smart sheets, on the rate methodology, and I just posted the link in the chat if you'd like to view any of those archived webinars as well.
Okay, we'll move on to the next question. From what I understand, the DLA 20 was not intended for use with the DD population, more for the MI population. So I think Dave will give us some clarifying information about that.
Okay. The OCHN provider network uses two different well-established research-backed DLA 20 assessment tools. The first one is the Adult Mental Health DLA for use with individuals 18 years and older with mental health, co-occurring, and or borderline and mild intellectual disabilities. The second is the intellectual disability DLA 20 for use with individuals presenting with moderate to severe intellectual disability. Using the right tool by trained staff ensures that scores are valid and inter-rater reliability is maintained.
And this is our last question that we had in advance. How will this tool be used to create better outcomes? I think Dave and I both probably have some things to say about this, and I'll let Dave go first.
All right. From a clinical analyst standpoint, this tool has already improved outcomes. Example, OCHN created the DLA 20i dashboard. The dashboard allows OCHN and the network providers to see what assessments have been scored and what assessments are in need of completion. It has the ability to identify treatment gaps with provider trends and to drill down to each individual served in our network. It identifies if the anchor is not scored with provider trends with the ability to drill down to each individual served, and allows the individual supervisor to address treatment gaps in clinical supervision to ensure that the assessed needs are integrated into the individual's person-centered plan with the proper staffing and supports in place. This has also put a spotlight on clinical staff training gaps, and OCHN addressed this issue by funding training for new DLA 20 trainers and the establishment of a cross MI and DD network-wide DLA 20 training cadre. This cadre is made up of DLA 20 trainers and is now able to adapt to the emergent training needs of the individuals we service in our network. And it's also allowed OCHN to address issues with our core provider clinical directors meetings, and has helped shape contract incentives to promote better service for individuals served in a network, for example, gaps in therapy.
So the only thing I'll add is that, because it is OCHN's responsibility to develop a robust provider network that can support the individuals eligible for services in our system, we really do have the opportunity now to use the DLA 20 data that we've gathered to look for gaps in service. So if we're finding that, we have a lot of individuals who have extremely high needs in one area, we can either go to the existing provider network and collaborate with them to develop new programs that help meet individuals' needs in this specific area. We may also find, that there are areas of expertise that we haven't developed in the network, and we can then go out to the community and look for training opportunities and look for ways to bring those things back to the provider network. So really from a standpoint of looking at capacity and looking where we need to add capacity or enhance the capacity that we already have, there's a lot of potential here with DLA 20. So that brings us to the end of the questions that we had in advance of the presentation. I'm gonna look to Tricia here to give us an update on any questions that have come in since we started.
We have only received one question in the chat, so if you do have any questions, please feel free to put them in there. The question we received is, does the DLA 20 assess physical impairment?
So the DLA 20 is not a tool that is going to assess specific physical impairments. What it is going to do is look at 20 areas across all of our lives where an individual might experience some functional challenge related to an impairment. When we train on DLA 20, we talk about how it cross-cuts across symptoms and diagnoses. And essentially that's a way to say that it's not really looking at diagnoses, it's not really looking at symptoms per se, but it's looking at the impact that diagnoses and symptoms have on a person's functioning in the 20 areas. And then when we have a sense of, based on information gathered and a DLA 20 score that's been given to an anchor, when we have a sense of the amount of support somebody might be needing in that area, we can go back and plan for those supports and services. So the simple answer is no, it doesn't specifically assess any symptom or any physical disability. What it does assess, though, is the amount of functional impairment somebody might experience related to a symptom or a physical disability or a diagnosis.
Okay. Somebody asked about a copy of the DLA question. So I did just upload a copy of the webinar slides. And again, the recording of this webinar will be sent out to you. Another question is, what is going to happen with the cysts?
There are no planned changes regarding the cysts. The cysts is the supports intensity scale that's administered in our network of providers supporting individuals with intellectual and developmental disabilities. That is one of our contract requirements with the Department of Health and Human Services, and we will continue to look to our core providers to complete cyst assessments as mandated in our contract with MDHHS. This is really a very different tool, and the administration of DLA 20 is not intended to impact the frequency with which the cyst is administered. They do have some overlap, however, they are very different tools. So we will continue with DLA 20 and we will continue with cysts as we have.
Okay. What is the provider's role in assisting with the completion of the DLA 20?
We're really going to look to providers and natural supports as well to provide information that they may have from their unique perspective on an individual's strengths and needs. Particularly with specialized residential providers, we know you're spending lots and lots of time with people as you're supporting them in their homes. So you're going to have a different and robust perspective on the strengths and needs that a person has. And to share those with a supports coordinator or case manager is going to be crucial. Again, it's not a collaborative process when we're talking about developing the actual score for each item on the DLA 20. because that supports coordinator or case manager is probably going to multiple sources of information, including sources of information like medical doctors, like other providers of vocational supports, for example, psychiatrists, therapists, etc., to get this information. So we're really going to look to the supports coordinator or case manager to be skilled in weaving together all of the information that they have to develop a score for each item on the DLA 20, where residential providers, where natural supports are going to have a lot of important information to share, is going to be around the areas where they are supporting a person and where they understand a person's needs and strengths.
Is the DLA 20 being used on individuals living in their own residence?
DLA 20 is being administered to all adults served in OCHN's system. That is all adults who have mental illness and all adults who have intellectual and developmental disabilities. The DLA 20 is not utilized in developing acuity tiers or utilized in any way in terms of establishing rates for individuals living in their own residences right now. It's only for use in specialized residential. So those would be licensed settings where individuals are receiving Medicaid covered supports and services right in those settings.
Can we get a copy of the anchors used in the assessment?
Yeah, I don't see why not. I think some of this information has been requested before, and so I'll work with our leadership here to see how we disseminate some of that information. There's quite a bit of information on the internet about DLA 20 if people have particular questions or want some additional background information as well.
I have a longer question here.
Sure.
I visit my daughter daily in her group home. I am elderly and would not be able to assist with her appointments. Would her score be affected because I visit so much?
Well, one of the areas that the DLA 20 looks at is family relationships. And so that might certainly be an area where the individual you're referring to has a strength. So yes, I would say that would affect the score. However, it's important to note that DLA 20 is really looking at 20 areas. And when we utilized DLA 20 data to determine the different acuity levels within specialized residential, what we were particularly focused on were areas where we thought an individual's support might require extra staffing supports. So we took lots of things into account around that. So I wouldn't expect one area per se to have an overall dramatic impact on the outcome, because there are 20 things that we're really looking at.
Okay. Can the provider attend the training being given to the case managers?
I would have to defer on that question. It's really, we really want to make sure that we have plenty of space and opportunity for the people who need to actually administer the tool across our system to come in and be trained. But that said, I'm not the person who would make that decision ultimately about who else could possibly attend. So we'll have to defer.
Are there any other additional questions? Oh, here comes one. Will DLA 20 be utilized for assessment of supports to be provided in vocational, non-vocational programs?
We actually already have a tool that we're using for individual supported employment that helps us determine level of acuity. There's not a plan right now to phase out that tool and phase in the DLA 20. That said, DLA 20 can be used extensively in the person-centered planning process to identify areas where supports and services need to be integrated. So it's not to say that it wouldn't have an impact or provide some useful information.
Okay. How do you get the medical information without violating HIPAA?
How does a supports coordinator or case manager get information about a person's medical needs without violating HIPAA? In many cases, supports coordinators and case managers are actually on the front lines supporting people in connecting with medical providers. In so doing, appropriate releases of information can be signed to allow medical providers and supports coordinators and case managers to appropriately exchange information. That's probably the simplest way that I can answer the question. If I were a medical provider, I would also have my own release of information that I would have signed by the individual and or their guardian. So it's a process that happens with most individuals who are receiving case management supports coordination services.
Any additional questions in the chat? I know we had a couple people who had called in on the phone. I'm not sure if they were also on the computer or not. You are able to unmute yourself if you're on the phone and you're unsure of, if you can't type in a question. But I'll give it just a couple more minutes to see if we have any more questions or anything comes up. Again, this is being recorded. It will be up on our provider training playlist that we have. I did link that in the earlier in the chat, so you'll be able to have a recording of this. A question came up was, did the OCHN board approve the use of the DLA 20 before it was used?
I don't believe we require board approval for this operational decision.
Any other additional questions? I want to make sure everybody has enough time to get all their questions answered. If there's anything additionally surrounding the DLA 20 that you would like to ask while our presenters and our team are here. And while we wait for additional questions, I will just say this did come out of one of our specialized residential and DLS provider meetings that the DLA 20 was discussed, and there was a lot of questions surrounding that, so that's why we held the webinar specifically for this. And again, there is a link in the chat box, so you do have a copy of all of these slides. You will receive within the next week a link to the recording as well, and I'll attach the slides to that again, and then any other additional attachments if needed. So we'll give a couple more questions. Here's another one. What is a GAF score in the PCP in relation to the DLA 20? So the GAF score in the person-centered planning in relation to the DLA 20.
So GAF stands for Global Assessment of Functioning. And of course, remember, DLA 20 is also an assessment of functioning. The GAF concept was part of the previous edition of the diagnostic manual that we use in behavioral health. It's no longer industry standard. Originally, DLA 20 was developed because the way that GAF scores were determined, at least this is one of the reasons DLA 20 was developed, the way that GAF scores were determined was found to be very inconsistent. So from provider to provider, one individual may have wildly different GAF scores. There was not a good tool to utilize to determine GAF score. DLA 20 is a tool that's heavily backed by research, and there is lots of data to demonstrate that it can be administered and re-administered even with different individuals who are trained in using DLA 20 doing the administration of it, and that scores are generally falling fairly close together so that there's much more consistency. In years past, there was a process that one could take a DLA 20 score and convert it into a GAF score. Again, as I mentioned, GAF is no longer the industry standard, so that's really not necessary any longer.
I have some questions about the scoring. Do you add up the 20 scores and divide by 20, or is there an adjustment? I am interpreting this as how the DLA 20 is scored.
Sure, yeah.
There's a way to calculate a GAF score that we're not using. Basically, for each of the functional dimensions that you answer, you divide by the number of functional dimensions answered. So if I answered all 20, I would divide by 20. Yes, and then you would get a DLA score. You multiply that by 10, which would get you an MGAF score that would fall between 10 and 70 on the DLA 20 assessment.
Fundamentally, what we're doing is we're scoring, adding up all of the scores for each anchor and then dividing by the number of anchors scored. That gives us an average score, and that is the final score on the DLA 20.
Okay. Which I think is with us promoting to answer all 20
yes.
of the anchors as well.
Right,
too.
right.
I have a question here that says, what if my supports coordinator refuses to redo the assessment when I request that it be redone due to inaccuracy?
Well, for purposes of making sure that that gets addressed appropriately, I would encourage a call to customer services.
We're putting the number in right now.
And those situations can be addressed on a case-by-case basis. Again, we continue to work with the sports coordination and case management agencies to make sure that they are clear on our expectations around DLA 20. Additionally, as I mentioned during the presentation, we're developing a process by which residential providers can request a review or appeal the outcome of the DLA 20 that is used to determine the acuity level and then a rate. So that more information about that will be forthcoming. But we would certainly, depending on who asked the question, we would certainly encourage a call to customer services. If it's an individual who's supporting somebody, a natural support, certainly customer services can assist in following up with the appropriate leadership at a core provider agency.
Yeah. And I did put that number in the chat, but it is 1-800-341-2003. All right. We'll give you guys, if we have any more additional questions, we'll give you guys a couple minutes for that. We still got a few people. Hopefully we've been clear and been able to answer the majority of your questions. Here's another one regarding the scoring.
Sure.
Does each score have its own weight, moderate or high? This is in regards of bucket of funding.
When we developed our rate methodology and then developed a process to look at DLA 20 outcomes to crosswalk those to the base, moderate, or high acuity rates, what we did was we looked at some particular items on DLA 20 and assigned more weight to those because it was evident to us that higher needs related to those items were going to necessitate additional staffing in specialized residential settings. So the question around are some anchors weighted more than others, I'm thinking probably references that bit of information. So that's how that works. Some anchors that we acknowledge are going to directly impact staffing in a residential setting are given a bit of a higher weight, and that can translate then into getting somebody to the right level of acuity.
So would that mean like if somebody needed assistance, more assistance in eating, dressing would require staffing?
Exactly, right. It also ensures that if somebody has like lots and lots of strengths, but there is one area in particular where they're going to need a whole lot of support that is going to require additional staffing support, that we're really parsing that appropriately and making sure that the outcome translates to the right level of acuity.
These are great questions that are being submitted. Any additional questions? Oh, we have some.
Can you hear us? 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 Can you hear us?
However, you are echoing. So if you're both on the phone and on the computer, we'll have to have you mute one for the other, if that makes sense. Okay. All right. Well, you guys do have the slide up. It's been up for a while, so you have Adam's direct contact. You can call him anytime. And again, you will receive an email from me, again, with the link, with the slides, making sure that you guys have opportunities if your question was not answered here, or if you didn't get a chance to submit the question, or you maybe even think about it later when you're discussing DLA 20 over lunch, and you could email one of us, and as I'm not a DLA expert, I will pass it on to those who are much smarter than me. So with that, I'll give it a couple more seconds if there's anything more, but I do not want to hold you guys too long. Thank you again for all of your interaction. Hopefully, we were able to answer your questions, and you will hear from us soon with the links and the attachments. Any last thing from our presenters?
Thanks for the opportunity. I hope this was helpful, and we look forward to continuing to work with you.
All right, great. Thank you, everybody. Thank you.